On behalf of both committees, thank you guys for inviting us to speak. The traditional ethos of this session is for the Systematic Review Committee to present evidence-based best practices for a condition, and then for the Quality and Safety Committee to mop up and show you the toolkit and how you can incorporate these ideas into your practice. But as you'll see in the next few minutes, evidence in this space is remarkably variable. And given the frequency that we encounter this problem, that's an interesting finding. So we're approaching this session backwards by starting with illuminating the frequent disconnect between patients and surgeons and each other. And we're going to start by saying that we have no disclosures. We're going to start by inviting you guys to open up the app and do some polling questions. Consider these questions like an auction. If you had your child recently recovered from non-operative management of perforated appendicitis, and there was zero risk of recurrent appendicitis or other complications, it's unlikely that you'd want to pursue interval appendectomy. So at what risk of recurrent appendicitis would you bid on an interval appendectomy for your child? 1%, 10%, 20%, 20 to 50%, or would you never consider an appendectomy? In the next question, consider the same situation, but instead of the risk of recurrent appendicitis, we consider the risk of appendiceal cancer. At what risk would you pursue interval appendectomy for your child? 1 in 100,000, 1 in 10,000, 1 in 1,000, 1 in 100, 1 in 10, or is the risk of cancer not a factor in your decision making? I'm going to open up those questions later, but first, one last question, and one of many shameless plugs for our toolkit. We're constantly seeking to gauge and encourage interest in this really excellent resource. We're going to present that survey data in juxtaposition with a survey that we performed among the members of the Quality and Safety Committee. This was a quick 13-question survey given over 3 days. To the 31 members of our committee, and in those 3 days we had a 61% participation, which I'm pretty proud of. We looked at preoperative planning, preoperative counseling, and operative approach. And the first responses clearly drive home the point that I made about the lack of good clinical guidance on interval appendectomy. 80% of our committee's membership do not have an established clinical pathway for interval appendectomy at their institution. And 60% would allow a perforated appendix to remain in situ. The vast majority of respondents perform an appendectomy at the traditional 6 to 8 weeks, but there were respondents that would remove an appendix at 4 weeks and respondents that would wait 3 months. And 80 to 90% would allow for some wiggle room and a significant delay in the timing of an appendectomy. This was the only question where we had 100% consistency. In the setting of a child with an undrained abscess, at the completion of that course of non-operative management, nobody in the committee would pursue interval imaging before interval appendectomy. When we moved to pre-op planning, the vast majority of our committee would perform an appendectomy as an outpatient. But interestingly, 40% of them would perform that outpatient procedure at an ambulatory surgery center where there was no opportunity to admit the patient postoperatively. The majority of our committee sees patients in pre-op clinic after discharge but before interval appendectomy, but there was a 50-50 split between whether those patients are seen in post-op follow-up. Now, patient counseling. When we asked about what we told patients about the risk of appendicitis, the most common response was a 20% risk. But as you can see, the spread moves to the right, and so the median was probably much higher. At this point, I'm going to pull up the results of our poll. 116 responses, you guys are great. Interestingly, the spread looks about the same. About 50% of the respondents would seek interval appendectomy for their children at a rate of recurrent appendicitis of 20%. 15 and 14% respectively at higher rates, 30% at any rate greater than 10%, and a smattering less than that. So we are counseling our patients consistent with what our own values are. I don't think it's going to be the same here, as the majority of the respondents to the Quality and Safety Committee survey do not discuss the risk of appendiceal cancer prior to interval appendectomy. And the results of this survey, are they shared? Can you guys see them when you open the app now? Because we can't pull them up onto the screen. You see them? Great. So then you can see these results as well. And anywhere above 1 in 100,000, parents in this room are pursuing interval appendectomy given the risk of cancer. So I think that there is a white space for good data for patient counseling and shared decision-making. And it's into this white space that I throw my colleague and new friend, Mark Cashton.
So these polls imply what many of us probably already suspect, which is that there's a high degree of variation in practice regarding interval appendectomy, suggesting both an absence of high-quality data and an opportunity to improve quality of care. With this in mind, we reviewed the recent literature to try to answer the question, what data exists for how to improve quality of care for interval appendectomy? One approach to this question involved trying to figure out how do we best facilitate shared decision-making around interval appendectomy. So in this 2022 study, researchers evaluated the efficacy of a decision aid for interval appendectomy developed by the Canadian Association of Pediatric Surgeons. The decision aid, which you can see over here on the right side of the slide, covers treatment options, risks and benefits of those options, and helps families identify their personal health care priorities. Families were tested on a decisional conflict scale based on their level of agreement with a series of statements about their decision, such as, I know which options are available to me, I know the benefits of each option, and other statements listed in Table 1 here. Families registered significantly lower decisional conflict scores after reading the decision aid compared to before reading it, and highlighting the importance of thoughtful and systematic approach to shared decision-making. As an aside, especially for those 50% or so of you who indicated that you have not heard of the APSA Quality and Safety Toolkit or not yet accessed it, tools like decision aids for non-operative management of appendicitis are some of the many resources available in this toolkit. It's an extensive repository of QI projects and resources that can be used to inspire or jumpstart quality improvement projects at your home institution. And I'll be displaying some QR codes on the following slides with links to some of these resources relevant to interval appendectomy. We don't have the Canadian decision aid from the prior slide, but Nationwide actually has an iPad-based decision tool for non-operative management, which is kind of very relevant. A second approach taken by several studies that we reviewed was evaluating quality in interval appendectomy by attempting to define what is the cost implications of interval appendectomy. You probably can't read any of this, but don't worry, you don't have to. So one approach to this question was to estimate costs through simulation, as in this paper out of Children's Memorial. So researchers built a decision tree model of interval appendectomy, which is what you see here, of observation after non-operative management versus interval appendectomy after non-operative management, ran 10,000 iterations of that simulation through a Monte Carlo model. Key assumptions in this model included successful initial non-operative management, a 15% recurrence rate without appendectomy, an 80% chance of needing appendectomy following recurrence, and a 1% complication rate following interval appendectomy. And under these assumptions, observation had a 40% lower cost than interval appendectomy. And following sensitivity analysis, observation remained the more cost-effective option as long as recurrence rate remained less than 25%. A similar study out of Utah also performed a Monte Carlo simulation, but with the goal of finding the age at which interval appendectomies break even from a cost-effectiveness standpoint. Key assumptions in this model include, again, successful initial non-operative management, which is probably something that can't always be assumed, a lower 6.7% recurrence rate without appendectomy, a 0.8% risk of major complications following interval appendectomy, and a 1.8% risk of complications after urgent appendectomy. The interval cost-effectiveness ratio was determined by cost per quality-adjusted life years, using a standardized willingness to pay threshold of $50,000 per quality-adjusted life year gain. And in this model, interval appendectomy, which is represented by the blue line over in this chart, was estimated to be cost-effective for over 80% of patients below 18 years, and for more than 50% of patients up to 33 years of age, after which relative cost-effectiveness was reversed, as simulated patients had fewer years of observation with which to develop recurrent appendicitis, appendiceal malignancy, IBD. In terms of non-simulated cost estimates, this is a 2012 paper from Le Bonheur that published the results of a randomized controlled trial of 131 patients who underwent early versus interval appendectomy. In a secondary cost analysis, they found that interval appendectomy carried a nearly 30% higher median cost, which is summarized up here, about $17,000 in the early appendectomy versus $22,000 in the interval appendectomy, all combined. Meanwhile, Table 1 summarizes some of the reasons that this might have been the case. Likely secondary to greater resource utilization, more central venous catheters, greater length of stay, as well as higher rates of adverse events and readmissions in the interval appendectomy group, as you can see here. The third and final group of studies we reviewed asked how does quality improvement improve with a standardized interval appendectomy pathway. So one such 2021 study compared 28 patients treated with initial non-operative management on the standardized protocol pictured here against 30 historic controls matched by demographic characteristics and disease severity. As you can see in Table 2, authors found that the patients treated on the standardized protocol had significantly fewer antibiotic days, 10 versus 14, less PIC utilization, 57 versus 100%, and less likely to be discharged on IV antibiotics. Length of stay was notably not different between groups. Similarly, a 2014 study out of Cincinnati Children's demonstrated that by utilizing their standardized protocol, pictured here, they were able to decrease PIC utilization and discharge on IV antibiotics by 2/3, decrease CT utilization by nearly 50%, and decrease overall cost by 6%, while decreasing their interval appendectomy rate from 20.2% to 6%. So what is the moral of the story? If you want to improve quality of care for interval appendectomy, you should be attentive to facilitating shared decision-making with your patients. You should be selective of which patients undergo interval appendectomy and cognizant of the impact of interval appendectomy on resource utilization and cost. You should consider developing a standardized pathway at your institution, and you should take advantage of the resources available in the Quality and Safety Toolkit, of which I've posted a few here. I'll now turn things over to our excellent members from the Outcomes Group.
Perfect. Good morning. Thank you. My name is Teddy Huerta. I'm a general surgery resident here representing the Outcomes Committee. We have no disclosures for our group as well. Thank you for the Quality and Safety Committee for that excellent presentation. We're not going to belabor that point too much, but overall, for acute appendicitis, as we all know, is one of the most common intra-abdominal conditions treated by pediatric surgeons, and up to 30% of children will present with perforation. However, the optimal management of perforated appendicitis continues to be significantly debated. The most common management strategies currently utilized include antibiotics followed by upfront appendectomy during the same hospital admission, or treatment with antibiotics with or without percutaneous drainage with eventual discharge of the patient and plans to bring them back for an elective scheduled interval appendectomy. But once again, no clear evidence on the optimal timing or selection criteria for interval appendectomy has been established in the current literature. So this was the knowledge gap that our outcome subcommittee sought to address by first wanting to target what is the optimal timing for interval appendectomy following complicated appendicitis, with particular regards to characterizing the incidence and timing of recurrent appendicitis after initial non-operative management. And then secondly, to help identify patient selection criteria and hone in on which patients would benefit from this management strategy, particularly also recognizing and being able to counsel patients with characterizing the rate of incidental malignancies found after interval appendectomy, as well as what risk factors are associated with failure of initial non-operative management. So through our initial database query, we identified 3,055 records that were screened by our interval appendectomy subcommittee. After application of our exclusion criteria, this resulted in 183 full-text manuscripts that we each individually reviewed within our group. And we excluded 126 articles, with the most common reasons being for those that studied the wrong patient population, those over 18 years of age, as well as the wrong publication type, those that primarily were involving review articles or not targeted as well to our outcome of interest within the scope of our research query. And this resulted in 57 full-text manuscripts that we have abstracted data and will be presenting for our qualitative analysis today. So we could have you open up the Whova app one more time. We have a series of questions we're going to get started with here. And the first one, so this is, you have a 7-year-old boy who presents with 5 days of symptoms and imaging findings consistent with a perforated appendicitis with a 4-centimeter well-formed abscess. In your practice, do you most frequently offer A, antibiotics and appendectomy upon admission, B, antibiotics with or without drainage with appendectomy prior to discharge, C, antibiotics and plans for a future interval appendectomy, D, antibiotics and drainage, no plans for an interval appendectomy or none. So we'll give that a second for everyone to answer. Okay, it looks like option C is the most popular so far, followed by option A. Okay, the next question is a 7-year-old boy presents with 7 days of symptoms and imaging findings, again with perforated appendicitis, this time with an extraluminal fecalith noted. Would you offer A, antibiotics and appendectomy upon admission, B, antibiotics, observe the patient and monitor their clinical progress, C, antibiotics alone with plans for a future interval appendectomy, or D, antibiotics without plans for an interval appendectomy or none? Okay, it looks like the majority so far, the most popular is A, followed by C once again. Okay, the next question, another 7-year-old boy presents with 7 days of symptoms and imaging findings consistent with perforated appendicitis, this time with a presumed intraluminal fecalith. Would you most frequently offer, once again, antibiotics and appendectomy upon admission, B, antibiotics admit for observation and monitor their clinical progress, C, antibiotics alone with plans for an interval appendectomy, D, antibiotics without plans for an interval appendectomy, or none of the above? Okay. Looks like almost 80 out of our 132 answers so far are choosing A, followed by C as the next most popular. And then if planning for an interval appendectomy in a patient who does well with upfront non-operative management of perforated appendicitis, when would you most typically recommend surgery? A, less than 1 month from their index presentation, B, 4 to 6 weeks afterwards, C, 6 to 8 weeks from their index presentation, D, 8 to 12 weeks from index presentation, more than 12 weeks from index presentation for option E, or are we completely out of our minds for option F? All right, looks like we have 138 participants, the majority 91 selected C, 6 to 8 weeks from index presentation. The next most popular is D, 8 to 12 weeks after index presentation.
Everybody out here is consistent with the Quality and Safety Committee.
Yeah, just in line with the data so far presented with the Quality and Safety Committee. And then our last question, if planning for an interval appendectomy and a patient does well with upfront non-operative management of perforated appendicitis, what would be the most common reason for which you would recommend surgery? A, the risk of recurrent appendicitis, B, the risk of an underlying malignancy, C, the risk of other long-term consequences, bowel obstruction, recurrent pain, D, the risk of hospital readmission, or E, are we still out of our minds? Okay, and it looks like the majority of participants have selected option A for the risk of recurrent appendicitis, which goes well into our next analysis for our first question for our systematic review. I'll turn it over to Dr. Tammy Levine from Joe DiMaggio.
Okay, so now that everyone is like super stoked to go home and develop your toolkits and get your institutions organized, even though we've just shown that there's significant variations in practice when it comes to the management of appendicitis, which is something that we all think we know really, really well and manage really, really well. We want to take a look at the data just to help you to develop an evidence-based approach to the development of your toolkits. So in looking at our literature, we noted that there were only 232 cases of recorded or documented recurrent appendicitis after an index admission with complicated appendicitis that was managed non-operatively. So numbers are really not that high. Looking at this data further, we saw that this was really broken down into about 26 studies that reported on patients who were managed non-operatively in the setting of complicated appendicitis who went on to actually pursue interval appendectomy, and that the follow-up ranged from a mean of 6 weeks to as high as 7.5 years, but that was really an outlier. The majority of the studies really have short-term follow-up. We're really lacking long-term data for these patients. So of those patients that recurred, the 232, some of the studies went on to look a little bit further as to whether or not there are identifiable risk factors that can lead you to counsel patients that perhaps that patient is at a higher risk of developing recurrent appendicitis. Now, we know that by study, the recurrence rates ranged from 0 to 26%, with a mean and a median of about 8 to 9%. 3 studies did report that about 2/3 of their patients who develop recurrent appendicitis did have a fecalith at their index admission. And only 2 studies reported on presence of an abscess at index admission, but did report that 80 to 100% of the patients with recurrent appendicitis did have an abscess when they initially presented. Now, there were 3 studies that reported some late onset recurrent appendicitis or some longer term data. These were patients who were managed non-operatively without the intent for interval appendectomy and actually seemed to present at a later date than what was initially expected for their follow-up. So one patient who elected not to have an interval appendectomy when they were offered to have an interval appendectomy at 6 to 8 weeks returned at a 10-month period with perforated appendicitis, and that was following their index admission. Another patient in a different study was lost to follow-up and returned at 8 months from the index admission with perforated appendicitis. And then one patient in that one study that I mentioned earlier with the longer time follow-up did present at 3 years after their index admission with perforated appendicitis. Now, it is notable that the majority of patients in that study who did have recurrent appendicitis had their incident of recurrent appendicitis within the initial 6-month time period from their index admission. So when we look at this data for the various studies that did report on recurrent appendicitis, we see that most cases of recurrent appendicitis do occur at about 12.5 weeks after the index admission. And that the majority of the studies, again, indicate that recurrent appendicitis occurs within that first 5 to 6 months of their index admission. Of the 1,915 patients that were treated with non-operative management with intent for interval appendectomy, 91% of them successfully did undergo interval appendectomy. And by study, this ranged from about 28% to 100%, but I'll note that the 28% was really an outlier. The majority of the studies who had patients with the intention for interval appendectomy were compliant with the interval appendectomy and at rates of 90 to 100%. So they did pursue their interval appendectomy. And of course, for us, it's always important when we're trying to counsel patients and trying to make decision plans on the management of these patients to consider complications as well. There are very few reported complications following interval appendectomy. As you can see listed, I'm not going to belabor this by reading all of the complications that were reported, and there was no ability to correlate these complications with the timing of interval appendectomy. So I'm going to hand the microphone to Katie.
Thank you, guys. So I was tasked with question 2 to summarize the data that we got from question 2. So when we looked at all of these kids that had complicated appendicitis, about 400 failed at their initial hospitalization, so they had an appendectomy instead of undergoing non-operative management. And then kind of as you move through this diagram, then another approximately 13 to 17% failed before they got their interval appendectomy, or at some point during their follow-up period. In terms of the question of carcinoid tumors, so how many of these kids actually had carcinoids? Is that something that we need to worry about? So you can kind of look at this data in different ways. I would say overall, the risk of carcinoid tumor is somewhere between 0 and 6%. We feel that that 6% is quite an outlier. So this is the paper. It was by Owen et al., and it's close to 20 years old now, but they had 36 patients, and there were 2 documented carcinoids in their interval appendectomy specimens. In overall, though, so this paper had 2 kids. In total, there were only 4 kids with a carcinoid diagnosed at that interval appendectomy. So if you look at 4 over the denominator of 1790 interval appendectomies, the chance of a carcinoid is about 0.2%. So pretty low risk of carcinoid tumors. And all of those kids were just treated with that appendectomy. This is our kind of diagram of what causes kids to fail non-operative management. So of those 400 kids, so if you look at these kind of brown and yellow areas, so these were all the reasons that kids might fail during that index hospitalization. The most common reason was small bowel obstruction. So if a kid presented with perforated appendicitis and a small bowel obstruction on CT scan, they were more likely to fail at that initial hospitalization. You can see it was really hard to kind of tease out what other reasons were important, sepsis, a parental request. They actually didn't want non-operative management. So one kid had an allergy to antibiotics, and somehow that made them fail, or kind of persistent ongoing pain and inability to get the kid out of the hospital. And then in terms of why did they fail kind of prior to their interval appendectomy, the reasons stated were a short duration of antibiotics, an abscess that wasn't fully treated, fecal lith was reported, a large phlegmon, or maybe a smaller phlegmon. So a variety of reasons, really hard to tease out what was kind of most important in that. So our conclusions, guys, were that in complicated appendicitis, where we tried non-operative management, about 10 to 20% failed at that index hospitalization. Then of those that were treated successfully at their index hospitalization, another approximately 8 to 9% failed before interval appendectomy. Fecalith and abscess are probably the most common reasons for failing, though the data is limited. The mean time to failure was 12 weeks, so it makes sense that people are recommending interval appendectomy at 6 to 8 weeks. And then we did see some later recurrences in the 5 to 6 month range. Most elective interval appendectomies are pursued between 6 and 10 weeks. The risk of malignancy is very low, and really there are just a multitude of reasons where people fail non-operative management without a consistent #1 risk factor. So I think the data is limited. We need long-term follow-up. Shout out to Dr. Kelly Kwan, who leads this group, and then also Dr. Levine, who led this project. We'd be happy to take any questions. Oh, no questions. Thanks, guys. No questions.